I'm very happy to present Dr. Khorshid Mohammed today and the team from Calgary. Really, the neurocritical care team in Calgary has been always very organized, and they have really had very significant presentations and contribution to this field. And we're very excited to have them today to present. So go ahead, Khorshid.
Thank you, Mohammed. Thank you, everybody, for joining today for our first neurocritical care round. And really, the idea of this round is just to start the ball rolling. And for this first round, we thought we will share our struggle, really, with this kind of problem and what we have done at each stage. And hopefully, it will be food for thought, and at the end of the presentation we'll learn from you guys that what are you doing to approach this problem that we are facing. And I will start with present two clinical cases. One of them had a severe illness but had good outcome, which we always like. And then the second case had milder presentation but had unexpected abnormal outcome, which always puzzles us. And then I will move to our experience with early exit from cooling and how we started and then we stopped it, and then how our project of mild HIE started and what we have learned from that, and how we developed our prediction tool that we are now using for our follow-up clinic. And then what are we doing currently and what are the future direction that we are thinking of doing, and that's where we really want your input and learn from your experience. So case one was typical 38 weeks AGA girl, and she was outborn, mom delivered by emergency C-section due to prolonged fetal heart rate deceleration. Apgars were 1, 1, 4, and 5, and the core pH was 6.88. The clinical staging was severe HIE as SARNAS 3, and the baby during the postnatal course had severe hypotension, required multiple normal saline boluses, on negative blood, and inotropes to correct the blood pressure. She was ventilated for a total of 6 days, and she had severe hypocapnia. The lowest CO2 was 23. She also had hypoglycemia. So this was how she looked before transferring it to our center. So I'll show you her EEG during cooling, but before going there, I thought I would just review quickly the 5 main patterns of amplitude integrated EEG, just in case if there's any trainees listening and joining us. So the first and the worst pattern is inactive or isoelectric. The upper half or the green half of the screen is the raw data or the actual EEG, and the lower bottom is the amplitude integrated EEG. And the system that we have and many centers as well have, you can create any combination you want of amplitude integrated EEG. And same for the raw data, you can have the simple central 2 leads raw data, or you can have a full EEG to look at. So in the isoelectric, you see that the bottom or the amplitude integrated EEG, the background is mostly below 5 microvolt, and the spikes are always below 10 microvolt. And if you compare that with the raw data, you would just see a flat line with some artifact every now and then. And then the second one, which is always abnormal as well, is burst suppression. So you get the burst and then a silence in between. The burst might be angry and might be soft. You might have like high amplitude, low frequency, or low amplitude, high frequency. And in between is either isoelectric or very slow signal. And if you look at the amplitude integrated EEG, the way to differentiate this from the isoelectric, the spikes are always above 10 microvolt. And the shorter the distance between the burst, the more dense the spikes are. So they are closer to each other. They call it spike density, and the denser the spikes, the better the outcome. And then the spikes become denser and denser, and the distance between the bursts become shorter and shorter to the point that it become discontinuous. So with discontinuous, you get like two distinct patterns. That's why they call it discontinuous. One is lower frequency, higher amplitude, and in between you got like higher frequency, lower amplitude. And the way it looks on the amplitude integrated EEG, you get a thick band, and if the lower border of the band is above 5 microvolt, the background will be normal. If it is below 5 microvolt, that will be abnormal. This pattern is normal in preterm babies, but it's abnormal in term babies. And then eventually it becomes continuous. So in continuous, you get a very narrow band, and if the lower border is above 5 microvolt, that's normal wakefulness patterns in term babies. If you look at the raw data, you will see a mixed patterns of frequencies and amplitude. You cannot make out any pattern out of it, and that's normal wakefulness pattern. And then the best pattern you get is sleep-wake cycle, where you get cycle between the continuous pattern and discontinuous pattern. Continuous when the baby is awake or during the REM part of the sleep, and discontinuous during the deep part of the sleep. And that's very normal. So this was our index baby EEG, and it was burst suppression. However, the spikes were very dense, so they were getting very close to each other. The background was very suppressed, and that went on for the first 24 hours. And then in between, she was getting this. And you can see that the EEG suddenly is becoming like ECG. And that's how the seizure present. It starts very shy, and then it gets mature, and then it fades away. And if this the rhythmic spikes are over more than 10 seconds, we call it electrographic seizure. And as the video goes, you can see that this seizure comes again and again, and in between the signal was very suppressed. So she had total of 28 electrographic seizures, and it was hard to control. We had to give 3 anti-epileptic drugs to control the seizures. And then we had the brain MRI, and also before showing you the brain MRI, I thought I would go over the main patterns that we follow here in Calgary and many centers as well. I would be interested to hear what kind of pattern of injury that you guys look at when you do your MRI. So the main pattern, the most classic pattern, is the acute profound asphyxia, where you get the basal ganglia involvement or the deep gray matter involvement and relative sparing of the white matter. So you get the thalami, the basal ganglia involvement, and the white matter, subcortical white matter, is usually spared. And also you get the motor sensory stripe involved, and you might get the optic radiation involved, and also the splenium of the corpus callosum. And some centers look at the myelination of the posterior limb of the internal capsule on the T2 weighted image, where the CSF is white. And if that's there, that would be a sign of good outcome. And the other area get involved in the acute profound asphyxia are the hippocampi. You can see them here. So for the acute profound asphyxia, you also will see the MR spectroscopy changes. And one thing to be careful with, if the baby has received phenobarbital, you might get the double peak that resembles the lactate peak. It's just farther a little bit from the lactate. So in this example, you can see them both side by side. The lactate is at around 1.1 ppm. And then the phenobarb vehicle is a little bit further. By convention, they put the voxel at the level of the basal ganglia. So if you have acute profound asphyxia, you should see lactate peak on the MR spectroscopy. So this is just a classic example. The lower row are ADC pictures, apparent diffusion coefficient, and the upper row is the T1 weighted image. So the lower row are day 4 MRIs, and the upper one are day 10 MRI. So you can see anything black on the apparent diffusion coefficient is abnormal. You see the basal ganglia and the thalami are involved, and the optic radiation which emerges from the pulvinar all the way to the occipital area is also dark. And you can see the hippocampi as well are involved. So that's classic acute profound asphyxia. And by day 10, the same area become bright on T1, so we call it T1 shortening. So you see the basal ganglia is bright on T1, and it's a U-shaped injury as well, the bottom of the cell side. The second common pattern is the partial prolonged asphyxia, where you get the white matter involved, not the deep gray matter. And this is the ADC MRI sequence. And you see that it's like a skunk sign. The bilateral watershed area is black, and it will be T1 shortening on day 10. And then when you get both of them, the basal ganglia and white matter involved, we call it total asphyxia. And it's, again, it's the ADC map. Black is abnormal. You see the deep gray matter is involved, and subcortical white matter as well. So that's total asphyxia. And the fourth one, if you can't put it in any of those categories, and you get like scattered white matter injury here and there, we call it like a multifocal HIE. And with multifocal HIE, you really need to go through the whole scan, because the foci might be at different levels. And in the video on the left, the pointer is showing you where the ADC map injury is. So those are the four patterns. When we report the MRI and we plan our follow-up here in Calgary, we follow that kind of assessment. And then the windows also, I was wondering if we get your feedback about the way we do the window. We have two windows. We do the first MRI at day 4 to 5, and that's the post-cooling, which, as you know, is not the best for predicting the long-term outcome. However, the families and the physician are anxious, and I don't think they can wait until the day 10 to 14 to know the result of the brain injury. The other reason why we don't wait until day 10 to 14, many of our HIE cases, they get discharged before day 14, so we don't want to keep them until day 10 to 14 just for the MRI. So for the post-cooling or day 4 to 5, you want to focus on the acute injury sequences, and those are diffusion-weighted images, ADC map, and MR spectroscopy. And day 10 to 14, you want to focus on the chronic or permanent sequences. Those are the T1 and T2. If you see T1 changes on the first window, it means the injury probably was on utero. If you see DWI and ADC changes on day 10 to 14 window, then it means there's ongoing injury. So this was the baby's, the index baby's MRI, although it doesn't show well here, but this baby had a bilateral thalami brightness and optic radiation, and the splenium of the corpus callosum, and also the U-shaped injury. And I think that this video will show it better. And you can see this is DWI, and anything bright on this image is abnormal. So this was coded by our neuroradiologist as total asphyxia. So based on the severity of the HIE presentation, based on the clinical seizure and electrographic seizure that was hard to control, hypotension requiring inotropes, and hypoglycemia, so we gave this family really like a guarded prognosis, and we said there is very high chance that this baby will have difficulties later in life. Then the baby was in the hospital at day 10. We repeated the MRI, and as you see the T1 on the left and the T2 on the right, the injury has shrunk. So those areas of the thalami involvement, that the optic radiation has almost faded away. I don't want to say disappeared, because it might be that we are just not capturing it. And then on the T2 weighted image, if you believe in the posterior limb of the internal capsule myelination, it was there as well. So this went on, and this baby was developed, was followed up in our neonatal follow-up clinic and has done really well. So her 18-month assessment was totally normal, from language, motor, hearing, everything was normal. And even at 2.5 years, she's totally normal. I'll just show you some video of her was shared by the family, and you can see her interacting with the dog, interacting with her mom, doing really some complex movement, and she's totally fine with that, and her development was quite normal. She's dancing at the end of it as well. So that was that. So we got it wrong, but that was like a pleasant outcome that every one of us has some of those stories that we are happy about, that we got it wrong and it turns out good. But this case was another one, which was the other way around. So this was a 41 weeks AGA girl, again outborn, exact same, was delivered by emergency C-section due to fetal heart rate deceleration. Upguards were similar, 2, 2, 4, and 5. Core pH was not that bad, 7.12. There was no hypotension. The ventilation was for 5 days, like milder hypocapnia. The lowest was 31, and there was no hypoglycemia. And so her EEG showed normal background, and she has some focal seizures. And as you will see that the spikes will come slowly and become more mature, and then it will fade away. And they were all subclinical. She had 3 of those, and it was easy to control. She received only a loading dose of phenobarbital. So normal background with focal seizure, the first thing you think about is stroke. So we did the MRI at day 4 of life, and this is the ADC map on the left and the MR spectroscopy on the right, and it was totally normal. There was no HIE injury. And this just shows you the T1 and T2, and the posterior limb of the internal capsule was there bilaterally, and there was no in utero injury. And that's why we look at T1 in the first window. And this just to show you the video of the whole sequence of the ADC map, and there was no abnormal darkness on the ADC map. So the MRI was at day 4 was totally normal. So we gave the parents a good prognosis, and we told them that this baby will likely have a good prognosis, and everybody was happy. And it happened to be, this was the first case that we have used our servo-controlled transportation cooling device, so we were all excited about it. But then at 6 months, she presented with this. She had a generalized seizure, which almost looked like infantile spasm. And if you look at the video, you will see that the 4 limbs clonic movement that she's having with the seizures. So this required quite a bit of anti-seizure medication to control, and we thought we might have got it wrong and we need to repeat the MRI. We must have missed some injury. So we did the MRI at 6 months, and it was still normal. This is just to show you the whole MRI on the T2 and T1, and there was no abnormality reported on the MRI at 6 months of age. And then luckily she was the seizures were controlled, and the repeated EEG at 10 months of age was normal. However, this baby had global developmental delay and learning difficulties. So the question we struggle with, like why we don't have the crystal ball, and that's the rest of the presentation. I will tell you our journey and story with this, the struggle we have with the prediction of the HIE. Just to give you some background about Alberta, so our population is around 4 million and we have around 60,000 births per year. The Southern Alberta Transport Service, the SANS program, we cover almost half of the province and we have more than 20,000 births per year. The incidence of asphyxia per 10,000 births, it used to be 1.67 and currently it's around 2.3 per 10,000. And the reason for the increment, what we think is probably because of better reporting. So we tried to look at the prenatal risk factors for asphyxia. That was the first step for prediction. And unfortunately, all the risk factors that we found were not modifiable. So there were things like priming gravida, having PIH, having gestational diabetic, uterine rupture, etc. They were all not modifiable. So we really stuck with the resuscitation, stabilization, and postnatal management. So therapeutic hypothermia in Calgary became standard of care around 10 years ago, and we get approximately 40 babies eligible for therapeutic hypothermia per year. Around 66% of our moderate to severe HIEs are outborn. So when we look at the percentage of babies they were eligible in retrospect for cooling and we missed in Southern Alberta, we were sitting around 27% compared to the rest of the country. It was around 25%, and this data is from the Canadian Neonatal Network outcome. So we said, forget it, like we have to deal with this. We have to decrease our number of the missed cases, even if we have to cool lots of babies. So we went to the outreach centers and we told them, like, you have low threshold for cooling. We are the tertiary center. We will exit them under a very controlled environment. So we developed an early exit strategy. We approached some centers that they have early exit strategy, like Bristol, they shared their protocol with us. So we put it in place. We said if the baby comes within the first 24 hours, if 2 staff neonatologists or 1 staff and 1 pediatric neurologist documented that this baby have normal neuro exam and the continuous video EEG was totally normal, then we will exit these babies from the cooling in the tertiary center. So doing that, we actually decreased our missed cases from 25% all the way to 7%, which was really good and we were happy about it. But there's always but. There was a couple of cases where after exiting them from cooling, one of them seized and one of them we had to do MRI for other reasons, and both of them had HIE changes. So we said, like, it's too high price to pay to keep this early exit strategy going on. So we turned around, we were back to square one, and we asked the group here, the Neonatal Neurocritical Care Special Interest Group, and thanks to you, like 33 centers had replied to our survey. The main question we ask is, do you have an early exit protocol? Only 6 centers had documented early exit protocol, and 8 of them said that we don't have, but every now and then we will exit the baby from the cooling if they look really fine. And then the other question we asked, like, when do you exit them? And the majority said we exit them within the first 24 hours. And then what criteria do you use to exit these babies? So most of the one that have early exit strategy, they use the normal serial neurological exam and normal EEG. There were 2 centers they used MRI as well. One of them was the Boston group. And then the last question we ask is, like, even if you have early exit strategy, do you actually use it? And when I was chatting in person with some of those centers, they said we rarely use it because there will be something on the EEG that we would be scared of exiting these babies from the cooling. So that was that. So we said then it's the early exit is done. We stopped our early exit strategy and we said, as many of the other centers, if you start a baby on cooling, you just keep cooling. We are committed for cooling. Then we thought we need to work on our identification then. If we are committed for cooling and we are not planning to stop the cooling, then we need to improve the way we identify the moderate to severe HIE babies. And the first question we want to start with, let's look at our mild HIE, the one we called them as mild at the tertiary center, how accurate our clinical staging was. And can we develop a prediction model from this mild HIE? Because all these cases were deemed to have normal neuro exam at the tertiary center. If we throw in some other tools like EEG and MRI, would that improve our prediction of the long-term outcome? So the first question was, is the stage 1 what we claimed our stage 1 HIE cases, they all have normal outcome or not? And in those cases that we committed and we kept the therapeutic hypothermia going, did they had better outcome? So we looked over around 10 years between 2006 and 2016. There's like typos, another zero, like way in the future there. So we had 126 infants eligible for cooling, and they were diagnosed at the tertiary center to have mild HIE, and the clinical staging was based on the admission diagnosis. We had, from those 126 babies, 86 cases had available MRI data, 71 cases with available EEG, 95 cases with available 1-year seizure outcome, and 95 with available neurodevelopmental outcome. So we were cooling around like 36% of our total cohort. So what we call the overcooling didn't really change from over the years at around 36%. As high as 16% of that cohort had abnormal EEG. That was either abnormal background or seizure, electrographic seizure. And as high as 26% had HIE changes on the MRI. And then when we looked at the long-term outcome, 6% had seizure at 1 year of age, and around 9.6% had CP or severe neurodevelopmental delay later on in life. And if you combine them together, around 11% had either seizure at 1 year or adverse neurodevelopmental delay. So then we said, what if we look at the clinical exam? What component of our clinical examination is really important? Can we shorten it down into like one component? One of our epilepsy fellow is doing a project looking at the duration needed for EEG, and while he was doing that, he looked at the component of the neuro exam that we are doing, and he found, interestingly, that something as simple as primitive reflexes was the best indicator for the abnormal MRI. So if you have the absence of the primitive reflexes, then the chances of having abnormal EEG and abnormal MRI was higher. So what if we combine the normal exam with the normal EEG and MRI? So then the negative predictive value become really high. So what we found that those babies which we deemed they have a normal exam within the first 24 hours, they had absolutely normal EEG, no abnormality, and they had abnormal MRI. All of them did well. So they had no abnormal neurodevelopmental outcome. So the negative predictive value was good, but the positive predictive value was not that great. So this was the one I was talking about, the primitive reflexes. The babies who had absence primitive reflexes, they really had a higher chance of having abnormal EEG, abnormal MRI, whether it's like any HIE changes, or if you eliminate the multifocal and you kept only the acute profound asphyxia, partial prolonged and total asphyxia, there were a much higher chance of having abnormality there. And as I said, the negative predictive value of the abnormal MRI was really high in those babies who didn't have absence of the primitive reflex. And it's very simple and easy to do. So based on that predictive model that we have developed, we have changed the way we are following our babies. So if the three things lined up, the neuro exam normalized within the first 24 hours and had absolutely normal EEG and normal MRI, then we don't follow them up for long term anymore. So we do the 18-month proper assessment, and if they are totally normal, then we hand them over to our neonatal neurocritical care clinic. If they have any abnormality in any of those three, we keep following them up until 3.5 years, and then we hand them to our neurocritical care clinic. And that opened the room for those unusual cases. So we have more capacity and resources to accommodate those babies that they missed cooling, or they had like unusual presentation but abnormal MRI. So we do follow them now in our neonatal follow-up clinic. And then we looked at the impact of cooling on the mild HIE, the one we called the mild HIE, and those babies, they were comparable, except babies with they were cooled, they were more likely outborn, and they had lower UPGAR score. So we put that in the regression analysis, and adjusting for that, the cooling has decreased the odds of abnormal MRI. There were no deaths in that population. That's why we didn't combine death or abnormal MRI, because they were all mild HIE. So to cool or not to cool, I think it still remains the question, and we are really interested in hearing what's your experience and if you have any advice of doing this differently. So what we are doing currently to address each one of these problems, we have put together an app. So instead of people deciphering our eligibility criteria, they can punch in and answer the question that the app asks them. And then the app will tell them whether the baby is eligible for cooling or not. And also, along with that, we developed a targeted neuro exam video which address each component of the criteria B of the cooling. And also, we developed the standard stickers people can use to document their neuro examination. And we put some cautionary there. We said allow around 1 hour for stabilization before making the call for encephalopathy, because we started to see people are jumping the gun and cooling the baby even at like few minutes of age, and some of those mom had medication and they would be like stunned for a while and then recover. And also we have had few cases where the babies really had fetal-maternal hemorrhage and had bad resuscitation then recover. So we said we would say 1 hour, before 1 hour don't make the call for encephalopathy, and then do the assessment. And we put some caution there. If the baby has DIC, if they're fetal-maternal hemorrhage, you probably should include those babies. And then we started use telemedicine as well, which helped us a lot. So we have few cases which we avoided cooling just by looking at the baby. So we will look, you will see the baby's moving spontaneously, have normal consciousness, normal posture, and you can see the vital signs as well. So most of the criteria B you can actually do by just looking. And we had like several cases where we avoided cooling. We still brought the babies here to our tertiary center, but we have not started the cooling. So just I will end up with this, like we struggle with uncertainty, but I think there is like a power and value in uncertainty, because the family keep investing in their baby. If we don't give them a definite outcome that this baby will be handicapped or bad, they wouldn't have that label locked mind, and they would keep investing, and that's invariably what improves the outcome. The involvement and the work of the family is what improving the outcome. Not knowing the outcome is not always bad, in my opinion. So acknowledge our neonatal neurocritical care team and the University of Calgary and Alberta Children's Hospital and Alberta Health Services. Thank you, and happy to take questions.
Thank you, Khorshid. This is Mohammed Al-Deeb. I had to be pulled away because I'm on service. But this app you just showed is very interesting. The question is, this app, do you think it's something that can be used outside your institute? It's something that people have free access to it? I know that the criteria could be different, but I'm just interested to know if this is accessible to other centers to look at.
Yeah, it's called HIE Calculator. If you go to App Store, it's free actually. And the guy who developed it, I think, will be happy to modify it based on your criteria. Like any center is interested, we can modify it and change the name and give you your own app. but people have found it helpful. They are using it a lot. Any questions?
Oh, hi there. This is Hannah Glass. Oh, hi. Can you hear me?
Yes. Hi, Hannah.
Hey, how are you doing? Very nice presentation. Thank
Very
you.
good.
I have a couple of comments, but I think my main question for patient number 2 is he had a genetic evaluation, because I think we can't forget that children with underlying disorders that may present with an encephalopathy picture and end up getting cooled, but not because the etiology is HIV.
Yeah, I think that's a very excellent comment, Hannah. Now what we are learning, like especially from neonatology, from you guys, the pediatric neurology, is that sometimes encephalopathy, as you said, is a symptom. It's not always HIE, and the underlying cause might be genetic. So yes, so they have sent the metabolic and genetic workup. That's a very good point.
Great. And then for case number 1, I think it's a really tricky MR, and I guess I'd caution people, so they really look like the pulvinar and optic radiations rather than the ventrolateral thalamus, which we see in the acute profound EI. And I think I saw Emily on the phone; she's more the expert, but we do see this in the setting of hypoglycemia, and it's not necessarily the devastating diagnosis that we might expect with a severe ventrolateral thalamus or basal ganglia injury. So I think that was a really nice example of a really tricky MRI. And then also in that case, you didn't show how that EEG recovered. We do see some kids that have an early terrible EEG and even bad seizures, but then have rapid recovery. So I was interested to see. I feel like the rapid recovery is a better prognostic sign than necessarily the early EEG. So do you have any information there?
Yeah, no, it has recovered. That's right. Like at 48 hours, it has recovered. Apart from the sharp transient, the residual from the seizure, it has recovered actually. Yeah, and I agree with you. The MRI is at the end of the day, it's a picture, and we really need to be careful with interpreting the MRI. We need to put it in the context of the baby.
Yeah, so I think that rapid recovery of the EEG is really important information, and then probably that MRI was more a watershed. The predominant injury was really watershed, which, as we know, can have a really good outcome. But really nice story. Thank you for sharing that.
Thanks, Hannah. And I think there was a question from Diane from Toronto. Like at what point you make the final decision for cooling? So the way we organize the targeted neuro exam when we go for the outreach program and the neuro exam stickers, we say if the baby at the first initial assessment is not eligible, then you have to do a couple of more neurological assessment, one between 2 to 3 hours and one between 4 to 5 hours. And if the 3 of them you are approaching the 6 hours, still the baby does not qualify criteria B, then we don't code them. So you have to do, the minute the baby qualify for criteria A, you have to do serial exam until you are out of the window of treatment, whether you use like 6 hour window or 8 hour or 12 hours, whatever you are using.
Oh, thanks, Khurshid. It's Diane. Can you hear me?
Yes.
Okay. I was actually asking about, sorry, I'm getting feedback. We're just turning the meet off. I was actually wondering if when a baby is assessed at 30 minutes and deemed, mild to moderately encephalopathic, but then by an hour of age has completely recovered with a normal neurological exam, and the baby has been passively cooled up until that point, would you still continue to cool those patients?
Yeah, so right now, whether that's right or wrong, whoever made the decision to cool, we don't stop it anymore. Because the reason why we found like this few cases where we decided to stop and then the MRI was done for other reason and there were HIE changes. So the group here felt that it's a too high price to pay, and then if somebody committed for cooling, we continue. And sometimes some of those baby, as you know, they come here and you just pull your hair and you say like, this is not moderate HIE, but somebody stopped the cooling, I can't stop it anymore.
Okay, thanks.
Can I make you, Hillary? You want to be a presenter? Yasser, can you make Hillary White a presenter?
Okay, sure.
She asked for that.
Yeah, Dr. White, you are now a presenter. You have to accept my invitation. And if you have anything to show us, you can do that.
Yeah, so there's one question about like if the baby did not have any criteria A, but had a sentinel event with some encephalopathy. The calculator said no cooling, but would you cool that or not? So I think the new Canadian Pediatric Society statement is adding the sentinel event to the criteria A. So if you have core pH which is between 7.01 and 7.15, and you have sentinel event and criteria B, then they would cool. I think the problem, a struggle I have with the sentinel event, it's sometimes vague and subjective, and it's hard to find. But if the story is compelling, it will become a judgment call, I guess, and sometimes you would make the call and cool those babies. So if there's this question about like many babies have abnormal neuro exam during cooling, but then how do you take this into consideration when you're thinking about stopping cooling? So when it's abnormal, regardless of the reason, we don't stop cooling. So if the neuro exam, despite cooling, that's what we used to do. We stop that now. If the neuro exam was normal despite cooling and the EEG was absolutely normal, and then we would stop the cooling. Right now, if the baby has been cooled, we commit to cooling and we don't stop it anymore.